I start off, I'd like to emphasize that I'm speaking on behalf of the state and not on behalf of any political party, because I find it most embarrassing when I sit on a panel and I'm supposed to speak on behalf of the state, and I find all parties, various parties represented, and I'm talking on behalf of, I don't know which party, so I'm talking on behalf of the state. I think the concept of primary health care, I don't know in what detail I need to go in primary health care, but the concept of primary health care is not new. It has always been an integral part of the health services of South Africa. And I think in the early days of our health services, primary health care was the only form of service we had. The Alma Ata conference, which took place in the week of 6 to 12 September 1978, under the auspices of UNICEF and WHO, looked into at the health status of the world. And they emphasized that millions of people die annually from preventable diseases. 50% of the world's population do not have access to adequate health care. In one of its articles, the declaration went on to say that governments have a responsibility for the health of their people. Okay, can you hear me better now? Which can be fulfilled only by the provision of adequate health and social measures. They went on to say that the main target in the coming decades should be the attainment by all peoples of the world by the year 2000 of a level of health that will permit them to lead a socially and economically active and productive life. They saw that primary health care was the key of attaining this target as part of development and in the spirit of social justice. In 1983, in South Africa, we adopted these principles in the Health Services Facilities Plan. But this plan didn't say who was going to do what and how were we going to attain these various goals. On the 8th of May 1991, the Cabinet accepted the principle that primary health care is the key to attaining health for all as part of development, and that local authorities, as the government closest to the people, should render primary care services. I'm going to be vague and speak generically. If you ask me what is the state's strategy, I want to start off by saying that it is based on the following 6 ethical principle values and 5 principles. We look at the ethical values. We look at the dignity and the right of every individual to health care. Because if you define the basic right and accept that right, and define what basic care is, you set the moral limit of what government should provide or subsidize. We believe, secondly, that there should be a caring relationship, especially in this time of high tech. That concept must be accepted. Thirdly, that the least well-off and able to care for themselves should have access to such services. But it's not only this, the responsibility of the state, but also of the individual, and also a general social responsibility. For the common good, and that we must rise above self-interest and focus on the common good. And here I'm talking of the health professionals, where we have to rise above our own interests, the community and sectoral interests. We have to look at cost containment, especially because of the legitimate demands for resources in other areas, and I'm looking at things like education, housing, etc. And finally, on the basis of simplicity of organization. These 6 ethical values overlap the 5 basic principles of acceptability, accessibility, affordability, efficiency, and equity. And on the basis of this, the strategy of the state is built. Our biggest criticism that we've had was the fragmentation, and I'm not going to go into the 14 departments of health and the various empires that were being built around it. But what I have to say is that since April this year, officially the various Home Affairs departments and the Department of National Health have got together
Unofficially, since September 1990, the Department of National Health, House of Reps, House of Delegates in the Western Cape have been trying to function as a unit. The staff, however, are all on the same establishment at present, and we're trying to reorganize so that we can have a leaner and a leaner machine. Have you got problems hearing me at the back? If we look at what has been done already, the various school health teams, of the various houses are being integrated so that we can render one service for all race groups. But we aim that this service should be rendered by the local authority based on the principle that was accepted, that local authorities should be rendering the services. But there will be specialized teams responsible to supervise the service and for specialized aspects of the service. If we look at community psychiatric services, in the Western Cape, we've already embarked on the rationalization exercise, where in the past we had various teams visiting the same area, seeing the same group of patients, all of them saying that they are seeing all races. But utilizing the same clinic, the same local authority staff, that service has already been reorganized. There is very little duplication on the ground at present, and we're hoping within the early future to have cut out all unnecessary duplication on the ground. If we look at the running of day hospitals or community health centres, as I prefer to refer to them, in the peninsula, we've already started to run them as a unit, although the people are employed by two authorities at this stage, province and national health. We have one person responsible for all the day hospitals run by the Department of Health, which were prior to this reorganization run by the various home affairs departments. Already we have extended services running 24-hour services in places like Elsie's River, Kailitsa and Mitchell's Plain, and within the next 4 to 5 months, hopefully we will be opening 6 more of these services to bring the services closer to where the people are. We know about the closing down of Woodstock Hospital. 130 posts from Woodstock have already been moved down to the community. Health information is now being coordinated and integrated so that we can have one set of data which will give us accurate and timeless information on which to plan and timelessly address urgent needs. We already have a single administration with administrative staff from the various departments being integrated as one unit. The medicine code list has already been adapted. We don't have various code lists, and there isn't one for the House of Assembly and one for the House of Reps and one for the province. We use the same code list, the same source of supply. The pharmacists from the various regional offices have come together, and that includes province, so that a pharmacist will be responsible for one specific area. And we won't have one pharmacist going to an older Joe and from another house going to district surgery and someone else going to the hospital. That has already taken place. When we look at primary healthcare in its totality, we've got to appreciate that it cannot be seen as something that is run in watertight compartments. The close association and interrelationship between health, social and economic development cannot and should not be ignored. Health leads to and is dependent on and leads to an improvement of the quality of life, but it is also dependent on the quality of life of the individual. So we see healthcare as an integral part of the process of socio-economic development. We've got to involve the community. The Alma Mater Declaration, as I said earlier on, said that people have a right and a duty to participate individually and collectively in the planning and implementation of healthcare. But this is easier said than done. Health workers have to be reorientated. They feel threatened. Our training in the past prepared them to make decisions on their own without consulting anyone other than their peers. And they ended up feeling that they could decide on behalf of the community. That whole component has to be retrained, and we've embarked on that already to try and make people realize that they cannot make decisions on behalf of communities, that they have to participate with communities, that they've got to look at other workers in the health field, and that it's not their sole right. So that will take time, but we have embarked on that already. Secondly, politicians feel that they empower and control funds and the purse strings, which leads to wrong priorities, uneven distribution of resources. They see community involvement as a threat. So the state has a responsibility, and its officials have a responsibility to act as enablers and facilitators. They have to educate health staff, communities, politicians. They have to be impartial and impartially inform communities on the implications of decisions, of the cost of services that they're having. They have to enable a dialogue to develop between the community and the health family. And of course, the state has a responsibility which it cannot run away from, of supplying the infrastructure and support systems to run the service. If we are to be successful, we have to involve the communities in their own service. With this in mind, we've started working on the situation analysis throughout the region. The only area where the communities are not yet fully involved, all the health professionals, is in the peninsula, for obvious reasons. But the Health Forum is an effort to address that shortfall. But we started throughout the region on the situation analysis, which involves health professionals and communities, where they actively look at the services, look at the cost of the services, the effectiveness of the services, the shortcomings in the services. They've identified duplication and needs. In this process, they are coming up with proposals, and it's interesting, they are redrawing the boundaries that we are used to. And these are aspects that we have to address. These proposals are looked at by a regional health coordinating committee, evaluated, and with recommendations to set up to central government where this is looked at again. This process has, however, led to communities and health providers coming closer together. The suspicion that we started off with 18 months ago is slowly but surely disappearing. New suspicions are coming up, new questions are being asked, but this is a healthy development. So if you ask me where are we going, as a state and state officials, we have the responsibility of being impartial, of facilitating and bringing about this dialogue. Seeing that there's equity, appropriate services, affordable services, and respecting the individuality of each community, because each community is different. We cannot sit in Cape Town and presume that we know what Springbok or Gullies or George needs. Each one is different, and we have to respect that. So with that as a background, thank you very much.